Hello, and welcome to another lecture from my class, PSYC 770, Psychological Testing and Assessment. As you can see from the title for this lecture, we're going to be taking a look at brief clinical instruments. Particularly, we're going to look at the SCL-90R and the Beck Depression Inventory II. I'll also take some time to talk about how we can divide up the continuous scores that come from instruments like this if we want to make meaningful decisions, like, for instance, admitting someone to treatment or not admitting someone to treatment based on their level of depression as indicated by one of these instruments. If we were trying to do that, we'd have to decide, well, where's our cut point, or where's our threshold above which we say admit someone to treatment, below which say we do not. Well, there's actually quite a lot of interesting methodology to making those types of decisions, or setting those cut points, I should say, for those types of decisions. And I'll just try and highlight one of the major approaches, rock curves, which I'll explain when we get to it. But before we do, let's just talk about brief clinical assessments. These have been around for quite a long time. If you think back to some of the history of testing lectures that we've done, there are early checklists that date back to at least the early 20th century, if not indeed quite a bit earlier. However, in the 1990s and onwards, the use of brief self-report instruments in clinical settings has increased, and there are probably some different reasons for this. One of them is probably the influence of managed care on healthcare. More and more people are getting their healthcare costs paid by increasingly more restrictive healthcare management systems and insurance systems, and many of these systems want to limit costs, so they're interested in making their providers use screening instruments or brief assessment instruments to make decisions. Does this person deserve more treatment? Do they need to be discharged? And so on. So when people look at the history of testing and they note that there's been an increase in the popularity of these instruments, one reason, at least one reason I've read multiple places, is that it has to do with managed care. Another reason may be just kind of like the diversification or the diversifying of roles for clinical psychologists. Psychologists generally are scientists who make and use tests, psychological tests. Clinical psychologists especially so. And if you're a clinical psychologist or a clinical psychology student, you know that you can wear different hats. You can become a researcher, you can become a teacher, you can work in clinical you can do clinical work. This diversity of roles makes it very attractive for many clinical psychologists to have brief, easy-to-use tools which they can use in research settings, in clinical settings, in policy and program evaluation settings, and so on. So again, maybe this is another reason why instruments like the ones I'm going to talk about are so popular, and have become more popular in the last decade or so. Okay, so well, what is a brief clinical assessment, or how might you select one? Well, all of them by definition are brief, and brief really has no precise number associated with it, but let's just say things that are maybe sort of 10 or 15 minutes time tops to administer, and maybe even to score up. And this makes sense because in most clinical settings, time is really at a premium. These are self-report instruments, focusing on the client's perception of himself or herself, and really limiting the amount of interpretation done by a test administrator. Also, they're instruments that can be administered to people with little or no advanced training for the test user or the test administrator. So you don't need a lot of training to administer a Beck Depression Inventory. Although I guess in this lecture and in this class we are going to spend some amount of time talking about that instrument and ones like it. But they're quick, they're simple, and of course hopefully they're relevant, or you could probably substitute in for relevant, they're valid, especially valid or relevant to the type of symptoms that we're interested in clinical settings, symptoms which are kind of categorized and in some ways I suppose kind of canonized in the Diagnostic and Statistical Manual of the American Psychiatric Association. We want instruments that measure those symptoms because those are the ones we care about when making diagnoses. We also like instruments which are fairly sensitive to changes in those symptoms. So the instruments I'm going to talk about today, and the ones that generally sort of fall within their boundaries or similar types, are all brief. they're self-report, and they're relevant for measuring symptoms of various forms of psychopathology. So without further preface or introduction, let's take a look at the Symptom Checklist-90-Revised, or SCL-90R. This instrument was originally, or in its original form, was the Brief Symptom Inventory developed by Dirigatis, I think I'm pronouncing that correctly, back in the 70s. And it is, or it was, what it sounds like. It was just relatively brief inventory of different symptoms for different forms of psychopathology that you could give to a client, or you could give to a research subject, or so on. It was revised a couple times. I think the most recent revision was in 1993, and it was kind of adapted and sort of expanded to be the Symptom Checklist 90, which was in 1994, I think. Anyway, the difference between these two is just basically the SCL-90R has an expanded number of symptom factors. I'll show what those are in just a few minutes. And it also has 3 global indices, which reflect overall level of distress or psychopathology. So what's it look like? Well, the client rates symptoms on 90 Likert item or Likert response items. It takes maybe 12 or 15 minutes to complete. I haven't checked this recently, but I think it assumes kind of like a 6th grade reading level, so you can give it to people who are not highly educated or do not have highly developed reading skills. Interestingly, you score it up using a computer scoring service that I'll mention in just a second. I'll have to check the technical manual for this instrument. I'm almost certain there's some way you could score it up by hand, but this is a test that's produced by Pearson or published by Pearson, and they really want you to use their scoring service, which is done online, which they charge you for. It's how they make some of their money, to score up the responses for these different factors of symptomatology, and also generate kind of a profile and a narrative for the particular client. And then if you really need to, you can refer to the scoring manual to interpret this profile. Although again, if you use the scoring service, you get a certain amount of narrative given to you by the service. And for what it's worth, this service is called QLocal. It's the kind of online scoring service that most, I think, or maybe even all of the Pearson/Psycore test products use. So this one, SCL-90R, MMPI-II-RF, the Milan 3, many other big tests are published by Pearson, Psycore, and some of them you can probably score by hand, but it's quite tedious. If you subscribe to this service, you pay a fee each time you sort of log in and upload information from a particular test taker's test, and then you get back a scored report. Note, if you think back to the lectures on ethics and professional standards, practicing clinical psychologists are allowed to use scoring services, but the responsibility is on us to be careful in our selection of them. So there are plenty of other services I'm sure you can find on the internet who would score up the SCL-90R or indeed other tests for you. If you were going to choose among them, probably you'd want to choose Pearson's system, because they're the people who developed the test and they have the best understanding of the reliability, the validity, the scope of the test. Well, what do you get when you get a scored up profile for a particular client? Well, you get a set of t-scores. You actually also get the raw scores, but the easiest to interpret are the t-scores, which, as you hopefully remember from previous lectures, have a mean of 50 and a standard deviation of 10. And typically what you do is you look across the profile of the different scores and you look for elevations. Elevations being values, t-scores that are higher than, let's say, about 63. So to translate that into kind of an awkward awkward language, you might say this is high average, or high, it's just above or kind of just outside of the range of what we would consider average. It's above 1 standard deviation, not quite above 2 standard deviations, but kind of getting there maybe. Now, what's really nice about the scoring service for the that you get if you use Pearson's Q local service is your particular client can get compared to different standardization groups or different norm groups. We use those phrases somewhat interchangeably. So if you're working with an adult psychiatric population or adult non-patients or adult psychiatric outpatients or inpatients or adolescents, there are different groups. So your test taker, the person who you've given the test to, we want to see where he or she lies with respect to the appropriate population. So if you're working with an adolescent, you don't want to compare them to adult psychiatric inpatients, because where their responses are in that population may not be really reflective of their level of psychopathology. And as you can see here as well, these norm groups are further separated by gender, and that can be really interesting and useful. So there's some real value, I think. I mean, certainly you should always compare each client to an appropriate norm or standardization group. There's some real value in using the Pearson system because it makes those comparisons for you, which is really handy. So you have your client, your test taker, compared to the appropriate norm or standardization group, and you can see for that person then their level of symptomatology on various dimensions, which are designed to be fairly resemblant to those in the DSM from the Axis one. So we're focusing really on things other than personality psychopathology. These scales, these dimensions, were developed to really emphasize clinical validity, to measure things which clinicians want to measure in clinical settings. And as I mentioned before, you also get these so-called global indices, which are kind of summaries of overall level distress, which are similar to what you'd find on the DSM's Axis 5, the Global Assessment of Functioning. So what are those symptom dimensions? Well, you can see them here, things like somatization, obsessive compulsive disorder, phobic anxiety. Those things seem fairly close to symptoms that we would find in the DSM system. There's some other things which are a little bit different, which are not quite within the wheelhouse of Axis 1 from DSM, but are things which clinicians might be interested in, like interpersonal sensitivity or paranoid ideation or hostility. And here is a rather fussy slide that looks at the factor loading of the different items on the SCL-90R. So if you count, or if you just squint at the little numbers, you'll see there are in fact 90 little boxes. Each box here represents a particular item on the test. There are 90 on the SCL-90R, and you can see how much each one of them loads on each of these different symptom factors or symptom dimensions. And the factor solution of this test, when it was when they were going through test development and going through factor analytic work, was done so as to kind of maximize the loading of these items on these different factors or dimensions. Here are those global indices I talked about before. Global severity, that's just the average across all items. It's going to give you, in a sense, an average picture of their overall psychological distress. There's the positive symptom distress index, which is the average distress for symptoms that were endorsed. So among the items that were endorsed at all, what's the average level of endorsement that people are giving, or that your test taker is giving, and then there's the positive symptom total, and that's just the number of symptoms endorsed, which is sometimes treated as a measure of breadth. So you could imagine different types of clients. One client or one test taker might only endorse a relatively narrow range of items, hopefully those specific to his or her distress, but endorses each of those at a very high level. So all of the items that she is endorsing, she's really maxing out, giving a number 5 rating to all of them. You can imagine a different type of client. He's endorsing a very broad range of items, but each of them at a rather low level. Those could be, or those almost certainly would be, very different clinical presentations, and you get kind of a numeric representation of that if you compared those two test takers, or those two clients, and looked at their respective global indices. I mentioned before that you get a profile back from the scoring system, and here's an example of what one of them looks like. Here you can see that we've got T-scores for each of our for our person, and their t-scores, they're different for whether we're comparing them to the non-patient sample or to the outpatient sample or to the inpatient sample, and you sort of select the one that you are focusing on. That's the one that's going to be at the top of that little table at the bottom there. And what you might do is just scan across the numbers, looking for numbers which are elevated around or even above 63. And so I've highlighted depression and anxiety have t-scores of 64 and 66 respectively. So they're quite elevated. Some of our global indices are also elevated as well, and you can see psychoticism there is elevated as well. Now, in addition to that profile, you get some narrative from the scoring service kind of describing what clients who have those types of elevations typically look like. I haven't included those in this PowerPoint, but I will in a different PowerPoint they'll provide later. What I want to focus on now is that in addition to those items which are designed to measure the different levels of symptomatology, there are also some additional items that appear on the SEL90 that don't add to primary symptom dimensions and do add to the global indices. So items which are not necessarily bumping you up on the depression scale, but do register on global indices and do just provide additional information that can be useful for screening or evaluation purposes. So these additional items include things like poor appetite, trouble falling asleep, thoughts of dying or death, overeating, awakening early in the morning, sleep that's restless or disturbed, feelings of guilt. Now, it's not to say that these things couldn't be related to different forms of mental illness, particularly we might imagine to depression, but the way that the scale is set up, or the way the test is set up, these items or questions based on them don't add towards those particular dimensions. They just appear in the report and provide some additional information. So this person's maybe elevates depression, and in addition they had acknowledged or they endorsed having poor appetite and awakening early in the morning. And so you might say, well, yeah, that seems consistent with maybe kind of a melancholic depression presentation. Or they elevated depression, but they also endorsed thoughts of death and dying. And so you could imagine a clinical setting thinking, oh gosh, I probably should have already done this, but I want to make doubly certain that I assess for suicide risk, because here I have an indication that this person has thoughts of death or dying. So that's the basic sort of form and presentation of the SEL90R. You can ask of this test, and you really should, and you should ask of every test, what do we know about its reliability and validity? Well, recalling that reliability can mean different things in different contexts, we can say that the temporal consistency as indicated by test-retest reliability over a 1-week period for the SEL90R is pretty good. Different studies have been done, and at least in my survey, brief survey of that literature, I was seeing test-retest reliabilities within a 1-week period of between 0.60 and 0.90. So those are really pretty good. Maybe those numbers would be lower if the time lag was longer, but that's not necessarily a knock against the test. We might well expect that over 2 weeks or over a 4-week period or over a 10-week period, things like depression and anxiety might change quite a lot. So a tight time window probably makes sense for test-retest reliability as a way of thinking about temporal consistency. If we think about reliability in terms of internal consistency, the Cronbach's alphas for the items from the different factors or scales are quite internally consistent. It wouldn't make sense to compute one big Cronbach's alpha for the whole test. I mean, you could, but recognizing that the test is multi-dimensional, you could instead, or you probably should instead, compute Cronbach's alphas for each one of the dimensions or factors, and if you did, you'd find that they're all fairly high in terms of their internal consistency, if we're thinking about reliability in that way. Well, what about validity? again, validity can be thought of in some different ways, and this slide that I'm giving you is not a very good one because it summarizes poorly an enormous amount of information. But suffice it to say that there are over 1,000 studies that have been done using the SAL90R, and no, I haven't counted all of them, and I certainly haven't read all of them, but I've read the technical manual, and I've read a couple good summaries like the one that appears in the Groth-Marnett Handbook of Psychological Assessment. And suffice it to say, this instrument's been around for a while, it's been used a lot, and in general, most studies find that it is valid, meaning that if we compare this test to some other test which we presume to be a criterion, we find a fairly close association between what the SAL90R says about a particular index, like let's say depression, and what another test, like let's say the Beck Depression Inventory, says about depression. Those will be fairly highly correlated. When we think about construct validity, one way we can think about it is in terms of convergent validity. I didn't emphasize this as much as perhaps I should have in earlier lectures, but you know, construct validity is this rather kind of broad, almost umbrella term to refer to the different ways that we evaluate the validity of a construct in this context as it is measured by a test. And one way we can do that is we can say, do the measures made by the test converge with other measures which we think are of the same construct? So we might not imagine that the Beck Depression Inventory is the perfect criterion for measuring depression, but we might say, well, it's at least fairly good at measuring depression, and thus we'd expect people's scores on the SCL90's dimension factor or dimension scale to be correlated or to converge with those same participants or test takers' scores on the Beck Depression Inventory. If we saw those patterns of predicted convergence repeatedly, we'd say, aha, this is providing us some information about the construct validity of the test. We could also think about validity in terms of content validity. This is, of course, a little bit harder to come to a numerical representation of, but it's worth doing. I mean, it's worth asking of any test, does this test capture the full universe of content that we think it should? And given that the whole purpose of the SAL90R is to kind of survey across all symptomatology that's relevant to clinical psychology or the practice of clinical psychology in clinical settings, there seem to be some things that are missing. One of them is mania. There really isn't a good dimension or factor on the SL90R for measuring mania, that important symptom, that key symptom for bipolar disorder. Nor is there a lot about the various symptoms or features of what we think of as personality disorders. I mean, interpersonal sensitivity, kind of sounds a little bit like some of the cluster B symptomatology back from DSM-4 TR's version of access to cluster B. Likewise, hostility kind of seems like a personality disorder dimension or feature. Psychoticism maybe as well, but it's not like there are personality disorder scales or factors on the SL90R. So that part of content is kind of missing. Mania is kind of missing. Psychoticism is used here in a way that's kind of consistent or in the tradition of personality assessment for psychoticism. Not psychoticism as in you are psychotic, you're having an experience of reality that's very different from that of other people, like you're experiencing hallucinations and delusions. Rather, psychoticism, I don't know, like the way personality researchers think of it, meaning you experience a sense of alienation from others around you. You feel different or unusual. You have a hard time connecting with others. That's not uninteresting to measure, but it doesn't exactly mesh with the way we think about psychopathology, at least not the way most clinical psychologists based out of the DSM system in terms of their thinking are thinking about psychopathology. What else can we do to measure validity? Well, we can look at the structure of the test, meaning we can look at the factor analytic structure of the test. And here we see, or rather I already showed you, that there are items on the test which load on these factors, and they load in ways that you might well expect. All the questions which seem to have to do with depression all go on the depression measure. One potential knock for the SEL90R is these deep factors are not independent of each other. These dimensions are correlated with each other. So if you elevate anxiety, you're probably also elevating depression. That might be problematic in terms of challenging the content, or I'm sorry, challenging the construct validity of the test if you assume that those factors ought to be distinct from each other. But maybe you don't make that assumption. I mean, the diagnoses on the DSM are not independent of each other. In fact, they're highly comorbid. So the fact that we see correlations, associations between these dimensions or these factors on the SEL90R might be a bit of a knock against the validity of its version or its kind of vision of psychopathology, or it might be just an accurate reflection of the way we think psychopathology really is. So if that sounds like an unsatisfying or even just confusing description, welcome to clinical psychology. A lot of stuff, especially in the area of testing, can be a bit like that. In the case of reliability, we can usually come up with some fairly good, often numeric representations of reliability. In the case of validity, it's often a little bit more ambiguous. Moving on, let's talk about another instrument here. Let's talk about the Beck Depression Inventory 2, an inventory that probably needs little or no introduction. You probably already know that this was developed by Aaron Beck and colleagues. You might know it was back in the 60s. It's been around for a while. It's a self-report instrument designed to assess level of depressive symptoms, and it was originally designed to test depressed inpatients. So, Beck originally, as a psychiatrist, was working with inpatient populations mostly, and he was measuring levels of depression, and he came up with this instrument as a brief clinical instrument to measure levels of depression, change in depression, and so on. It's been revised over the years several times, or I shouldn't say several times, it's been revised one time by Beck and colleagues in the late 1990s, and that was done at least in part to make it more consistent with the DSM criteria or the DSM symptoms for depression, to kind of make it fit a little bit better with the DSM system. Now at this point you may pause for a moment and wonder, maybe it's problematic that we've got tests like the SEL90R and the BDI, and indeed many other tests, the MMPI we'll see in down the line in later lectures. Maybe it's problematic that we've got these tests trying to fit themselves to the DSM if we already know that the DSM is kind of a flawed or at least non-optimal way of thinking about psychopathology. And the DSM categories are developed largely by kind of committee consensus. They're non-independent and highly correlated in some cases. They seem to provide an incomplete picture of psychopathology. That's life. That's clinical psychology. That's psychiatry. You could almost wonder, having such a kind of a hinky, flawed diagnostic system is problematic for all sorts of reasons. One of them is we have tests which try to be like the DSM, and in doing so, maybe they get it wrong, like the DSM gets it wrong. Oh well. It's what we're stuck with for the time being. Anyway, I think I already said this, but I'll say it again. Beck Depression Inventory 2, the current edition of it, it's widely used. It's probably one of the most widely used measures of depression, in part because you can very easily get it for free off the internet, even though technically you should pay for it, which we here at NDSU have indeed done. What's the form and purpose of it? Well, it's obviously to measure levels of depression. It consists of 21 4-point Gutman items. Gutman items are just a way of doing test items, where instead of having a particular item and then a response choice, like here's an item rated on a 1 to 5 Likert scale, each item is kind of rendered in multiple versions, often ascending in severity. So if you've looked at a Beck Depression Inventory, you know that each of the little numbers corresponds to a set of statements, 4 statements, and the lowest one is like I don't cry much at all, and the highest one is I cry uncontrollably all the time. So the more you pick the higher items, the more you're indicating a level of symptomatology, in this case depression. And you probably already know the Beck Depression Inventory is very quick to administer. It takes maybe 3 or 5 minutes. It assumes a relatively low reading level, which is good, just like the SAL-90R. It requires no scoring system or software. You just total up the numbers by hand, as I'm sure many of you have if you've worked in clinical settings or in research settings that have used the BDI. And it measures all these different sort of features. There are things like sadness, pessimism, failure, loss of pleasure, suicidal thoughts and wishes, crying, agitation, and gives you one overall summary of what the person is like. If you sum up all those items, you get a sense of overall how depressed they are. And the total can be interpreted in different ways. And one way, following from the scoring manual of the test, is to consider people who have very low scores to either have sort of no depression, or maybe even be in denying depression, maybe being kind of presenting themselves as overly healthy or stable of mind. So that's probably a bit controversial. I mean, I would hesitate as a clinician to say, well, your Beck Depression Inventory is 0 or it's 1, you must be lying to me, but it's at least worth thinking about. More generally speaking, people who score kind of in the 0 to 10 or 0 to 13 range, we consider them to have minimal depression. If they're scoring in the teens, it's mild depression. If it's 20 or over, it's moderate or even severe depression. A little bit later on, I'll return to this idea of creating cut scores or thresholds when I talk about ROC curves, because these cut scores that you can see here are somewhat arbitrary, but they are based also on some psychometric evaluation. And it's actually rather interesting, and not so much in the lectures, but in the class for my course for PSY 770, we'll talk a little bit about this. So you can ask about any test, you can ask about the Beck Depression Inventory. What do we know about the reliability and validity? Well, again, if we think about a retest reliability to indicate temporal consistency, and if we allow kind of a 1-week lag, which seems reasonable for depression, then the temporal consistency is quite good. It's in most studies it's in the 0.90s, which is almost as good as you can get. Similarly, if we look at the internal consistency of the Beck Depression Inventory, it's pretty good too. In fact, it's very good. In most studies, it's in the 0.80s or 0.90s. And given that we really think mostly of the BDI as being a unidimensional scale, it makes sense to just compute a Cronbach alpha for it. And if you did, you'd probably find fairly high internal consistency. Validity. Well, here comes another one of these really kind of vague slides. There are thousands of studies that have used the Beck Depression Inventory, and for the most part, they find that it is associated with other measures of depression. So there's convergence between this measure of depression and other measures of depression. And if we take those patterns of convergence as indication of the construct validity of the test, then we'd say, yeah, there's probably pretty good evidence for the construct validity of the Beck Depression Inventory. What about the structure? If we think about construct validity from a more structural perspective, can we factor analyze the Beck Depression Inventory? Well, they've done that. In fact, they've done that a bunch of times. In general, you do find factor solutions. By the way, I think I mentioned this in class the other day, but I had a professor back in undergrad who was I won't say he was skeptical of factor analysis, but he had a healthy regard for it, healthy skeptical regard for it. And he said, look, anytime you do a factor analysis, you'll get a factor solution that will almost always be more than one factor. So indeed, if you take the Beck Depression Inventory, which seems to mostly just measure one thing, depression, and run it through a factor analysis, you usually get 2 or sometimes 3 factors. In terms of most of the literature, these are often characterized as the non-cognitive or sometimes somatic vegetative factor, awkward, versus the cognitive affective factor. Put another way, you typically get one factor which is mostly the items that have to do with how bad you feel physically when you're depressed, or some of the loss of energy, disruption of appetite, etc. And you get this other factor which is kind of how you think and feel when you're depressed. Like, I feel sad, I have confusion or decreased attention and so on. And that kind of makes sense, at least clinically. I think if we've worked with people who are depressed, you sometimes see what almost looks like these two kind of distinct facets or features of the disorder. There's this kind of crummy way the person physically feels, and then there's everything else that's kind of going on, for lack of a better phrase, upstairs, in their head, their thoughts and feelings. Indeed, I'll just add here, one time when I was on internship, I was in a clinical trial of a particular form of therapy, and because I was curious, I got permission from my supervisor. I repeatedly administered the Beck Depression Inventory over a course of weeks as I was treating this one client, and I just computed the scores for each of these putative factors, and I graphed them in Excel and showed them to the client at the end of treatment, and showed that what happened for her initially was that kind of there was improvement in this somatic factor, this non-cognitive factor. She started to feel physically a little bit better, and then over time kind of the cognitive affective factor caught up, and her symptoms improved in that dimension as well. And for what it's worth, in this N of 1 time series, that kind of made sense to her. She reflected that it did feel like it took a while for her feelings to catch up with her treatment, but they did, and I was very happy. I was proud of her, and she was happy too. So hey, clinical psychology, being a scientist practitioner, good for me. Hopefully good for you too when you get the opportunity. So I said this before, and I'll say it again now. Oftentimes when we use brief clinical instruments, we're using it to make decisions. Now this isn't always the case. As in my example for my internship, you could just use the Beck Depression Inventory to measure level of symptoms, or level of kind of overall depressive presentation, and that would be fine. In fact, that would be consistent with really the purpose of that test. But you could imagine a situation in which you used that test to make a decision. If someone's Beck Depression Inventory fell below the teens, if their score was in the single digits for 2 weeks in a row, you might say, well, this person's probably responding to treatment, or they are maybe eligible to be discharged from treatment. If not, then we're going to keep them in treatment. Some sort of binary decision that you're trying to do. Well, brief clinical instruments are useful for this. They're not always used for this, but they're useful for this because they produce these these continuous scales, which can be subjected to various thresholds or cut scores. So I haven't mentioned this before, but a good example of this would be the Centers for Epidemiological Studies Depression Scale, or CESD. It produces scores that range from 0 to 60, and in terms of the research that's been done on it and the way it's typically been used, usually if you have a person with a score above 17, you say that person's depressed. So you make a binary decision as a function of their position on this continuous score. So let's say we have a brief clinical instrument that yields a continuous scale, but we want to make some sort of a binary decision. We have to set a cut point. So how do we decide where to put it? Well, how we decide where to put it is going to be influenced to some extent, actually to a very large extent, by the amount of overlap between the responses that people who have the disorder give and the responses that people who don't have the disorder give. So you can kind of see this represented here in this image. Imagine that there's some range of values, scores from one low end to the high end, that people who really have depression tend to give. And then there's a range of responses from very low end to a very high end that people who don't have depression give. Those ranges might overlap. In fact, they probably will overlap. Probably for most of the things that we might choose to measure in psychology, or especially in clinical psychology, there'll be some overlap. So depending on where we put our cut score, we can end up incorrectly classifying cases or missing cases. So you can imagine different cut score options here. Let's say we begin on the very far left, and we say that anyone who has above this rather low value indicated by the solid black arrow on the far left, anyone who has over that value, we're going to call them depressed. Well, that's going to work great for all the people who really do have depression. We'll have caught all of them, but we'll have also misdiagnosed. We'll have created false positive errors for all the people who don't have depression. So again, it depends a lot on the situation and the context in which we're using testing, but that doesn't sound very good. Let's say we take the black arrow and we move it all the way over to the second position there where it is, kind of a little bit right of the middle of the slide. Well, this is great. If we say our cut score is now at this point, we're no longer making any false positive errors. No one who does not have the disorder is incorrectly diagnosed. But we've now created at least a few false negative errors, because there are some people who really do have depression who now fall below or to the left of our cut score. So we've made some errors there. Well, that's not great. Let's imagine then we switch over to the white arrows here, and we put our cut score kind of almost dead set in the middle of the range. Well, this isn't great because if we have, or this is great, I suppose, in some respects, because anyone who scores above that point is diagnosed as depressed, and that captures everyone who really does have the depression, but we've still got some false positives. Alright, so now we're getting really frustrated. We move our cut score really, really high, and we say, okay, you have to exceed this really high value to the right of the white arrow on the very edge of the range. If you exceed that value, then you're depressed. Well, we're now no longer making any false positives, but we've now created a ton of false negatives. So you can see, I hope, as awkward as my description is, that by sliding that arrow left or right, or equivalently raising or lowering a cut score, we're going to end up with different ranges of correct diagnoses and different ranges, or different possibilities, I should say, of incorrect diagnoses, or false positives and false negative errors. There's no easy way to resolve this. Depending on the amount of overlap, there always will be some errors. In fact, as a general point, there's always errors in all measurement, including in this type of measurement. And when we make cut scores, we're always going to have to use a certain amount of judgment, and we're going to have to think a lot about the risks associated with mischaracterization of people. Depending on what we're talking about or what we're trying to use this test for, it may be a really bad thing to have false positives. Or maybe it's not that bad a thing. It may be a really bad thing to have false negatives, or maybe it's not that bad a thing. It depends on the amount of overlap, it depends on the nature of the testing and the purpose of the testing. There's also this kind of basic issue that we really have to acknowledge or be honest about, that we're dichotomizing a continuous outcome variable. It's probably the case that depression in some sort of deep real level is continuous. That it's not the case that people are not depressed and then they are depressed and there's no possible overlap. That's probably what depression is really like. Certainly there are personality dimensions that seem very much like that. They seem continuous or dimension-like. And anytime we try and create a cut score, we necessarily simplify the complexity of nature, which could be a problem. It might not. Again, it depends a lot on what we're trying to do. The other thing we just have to think about or worry about is, again, how do we decide exactly where to put that cut? And there actually are different ways to do this. None of them are perfect. Some of them are very complicated. I'm going to show one that I think is relatively easy to understand and is also just kind of cool. And that is the receiver operator characteristic, or ROC curve. And you can see a very nice looking ROC curve here. It is a curve that kind of plots a curvilinear relationship between false positive rate and true positive rate. And if you think really hard, back to our last class, our last lecture, that'll start to ring some bells, and you'll maybe see where I'm going with all of this. Within this system, there are four outcomes, of course. There's a true positive, true negative, false positive, false negative, or if we want to summarize a little bit, we could say hits and misses. Clearly, we want to have a system of decision making where we maximize hits and minimize misses. And in order to do that, we can make some calculations. So for instance, we can calculate sensitivity. That's the probability of test positive given status positive. Specificity, probability of test negative given status negative. So sensitivity and specificity tell us, in a sense, about situations in which there are hits, where the test gets it right. Test is positive given that status is positive, test is negative given that status is negative. What about misses? What about mistakes? Well, we can calculate different ways, but one thing is to look at the false positive proportion. So that's probability of test positive given status negative, which you can see here. And interestingly, just arithmetically, the false positive proportion is going to be 1 minus the specificity, because if test is negative, if status is negative, the test is either going to be test positive, a false positive, or it's going to be test negative, a true negative specificity. We can also calculate the false negative proportion, which is the proportion or the probability of test negative given status positive, which, as you see, is just the arithmetic inverse of the sensitivity. Because again, if we think about situations in which status is positive, the test is either going to be negative, that's a false negative, or it's going to be positive, that's a true positive, a hit sensitivity. Now, in thinking about all this stuff, sensitivity, specificity, false positive proportions, false negative proportions, I'm starting to think a little bit about radar. And there'll be a very specific reason that you either already know or you'll see very soon about why I'm thinking that way. Like, imagine you're a radar operator and your job is to monitor with your radar set the sky, and you're looking for airplanes. Maybe you're a flight traffic controller, maybe you're working in the military looking for enemy aircraft, I don't know, whatever. Sensitivity is, we can think of as the probability that the radar, the test, says that there's a plane in a particular region of sky, given that there really is one. And specificity is like the probability that the radar, the test, says there's not a plane, test is negative, when the status is really negative. There really isn't an airplane in that part of the sky. And false negative proportion is just the probability that the radar, the test, says there's not a plane if there really is a plane. So again, that patch of space up there, maybe there really isn't a plane there, in which we've got specificity, the radar says no, and there is in fact no plane. Or we maybe have a false negative. The radar says there's no plane, but there really is a plane. And that could be a problem if you're an air traffic controller and trying to keep planes from crashing into each other, or if you're working in the military and you're trying to detect an enemy bomber that's inbound. This isn't just a weird metaphor or connection that my mind makes. This is one with deep historical roots. Radar, or radio detecting and ranging, as you probably know, was developed in the 1940s and 1950s. If you're a historian of World War II, you know it played a very important role in the Battle of Britain. And it's fundamentally about detecting signals. So in this case, the signal is a returned radio wave that bounces off of an aircraft and returns to the receiver and is displayed on a screen that the radar operator watches. And there's this other phenomenon of gain. Gain is how much that signal gets amplified. And if you play a musical instrument, maybe especially if you play like an electric guitar, or if you're just, have ever messed around with a hi-fi stereo set, this idea of cranking up the gain, sort of maximizing a signal to make it louder or more present in the mix of the audio. And so you can imagine very literally what a radar operator used to do, and computers do it nowadays, but back in the day you would have one set of knobs to aim the radar into a particular point of space if it was a directional radar, and you'd have another set of knobs that would adjust up or adjust down the gain of your radar set. So if you had very low gain, you weren't amplifying those returning signals very much. You'd get few true signals getting detected. There'd be few true positives, but you'd also have few false positives. So if you weren't particularly suspicious about there being incoming bombers back in World War II, you might want to keep your gain down really low, because you don't want false positives, because if there's a false positive, you have to scramble all your aircraft and waste a lot of fuel and maybe risk people hurting themselves when they crash, if they accidentally crash on their way back in. So you keep your gain very low, but you might miss a real bomber, a real true signal, a true positive. So you might crank your gain up, turn that gain up, turn the volume knob. Volume isn't exactly gain, but it's close enough for our purposes, on your set very high. Now every little errant signal that bounces back to your receiver is maximized. And that's good, because you'll have a lot of true positives. Any bombers up there are going to get detected by your radar set, but you'll also have false positives, whether it's a cloud or a bird or just some weird atmospheric anomaly. You'll get an errant signal which will come back and get amplified and turned into what appears to be a signal on your set, except it's a false positive, a false signal. And then you scramble all your base's aircraft, and you mobilize the anti-aircraft guns, and everyone waits around and nothing happens, and maybe you get in trouble, or that's bad. So back in the day when this was all really happening in wartime and in after wartime during the Cold War period in the America and Britain and elsewhere in the world, a set of theories were developed to guide or to understand how things like gain affect detection of signals in stuff like radar and electronic communication. And this is called signal detection theory. It was used in psychophysics later and around the same time as well. So, again, people who are engineers and aeronautical engineers use this. Also, people who are sort of thinking about stuff like how does the human brain detect a light source. We're also using this signal detection theory, and depending on the classes you've taken or the labs you've worked in, you may be familiar with some of this stuff already. What I want to do in this class, in this lecture, is make a connection from that world to this world that we're talking about, the world of psychological testing. And it's not a hard connection to make. In our world, the signal is the score on the test. And the gain is just the decision you make about that score, where you set the cut score. Is the cut score set very low, or is the cut score set very high? So let's think about a low gain situation. If your cut score needs to be very high before a decision gets made, that's equivalent to having low gain. You're not amplifying the signal very much. Someone returns a test to you, the test has a score of 12, but you need to have a score of 20 or above. I'm just arbitrarily saying this is like a Beck Depression Inventory. A score of 20 or above before you diagnose the person with depression. That's like a low gain situation. You're not amplifying that person's score. That means you're going to get few true signals, few true positives. You will miss some people who really are depressed, but for whatever reason don't answer the instrument, the test, in a way that exceeds your threshold. But you'll also have few false positives. And again, maybe that's good, maybe that's bad. It depends a lot on the context in which you're doing the testing and what the purpose of testing is. Compare that to a high gain situation. A high gain situation would be where you set that cut score really, really low. So a person returns a score on his test or her test of 12, but they only had to get above 2 in order to be diagnosed as depressed. Well, you set that cut score really low. That's equivalent, or I should say analogous, to having a really, really cranked up the gain on that radar set. So even the smallest signal gets caught or amplified. Well, if you set the gain really high, equivalently meaning if you put that cut score really low, you'll have more true signals detected. You'll catch more of the people who, in this example, really are depressed, but you'll also have more false positives. People who aren't really depressed, but they exceeded that low threshold that you set and were amplified, so to speak, to being diagnosed as depressed. Now, whether that's good or bad depends a lot on the context of testing, kind of like we talked about before, but it's just the connection I'm trying to make. The signal is the score on the test. The gain is where you set the cut score that is used to interpret that score on the test. So here's a funny example that I came across in a reading that I did a while ago, quite a long while ago. Imagine that there's some new disorder called photonumerophobia, which is the fear of seeing numbers. And this doesn't exist as far as I know, but we're talking about math stuff, calculations. I know this makes some people anxious. Let's imagine there is such a thing as this specific fear of just even seeing numbers. And let's imagine you made up a scale for photonumerophobia that ranges in values from 1 to 10. So higher scores are associated with a greater likelihood of having PNP. Photonumerophobia, hereafter PNP. Now there could be different cut scores for where we put on our scale for diagnosing photonumerophobia. And let's just assume, if we were to make two histograms, that there's some range of scores in which people who have the disorder tend to answer, and that's the dotted line, sort of, or the dotted histogram on the right. And there's some range of scores, a distribution of scores in which people without the disorder tend to respond. But unfortunately, as is almost always the case in psychology, there's some amount of overlap. If we put the cut score at point A and say, okay, anyone who goes above point A, whatever that is, 2, 4, they're diagnosed. Well, good, we caught everyone who really is PNP, but we also had some false positives for some non-phobic people who were mistakenly diagnosed, false positives. If we put the score, the cut score at B, we kind of drop the gain down a little bit by raising the cut score to wherever B is. Well, this is a little bit better. We're not doing as many false positives, but we're also now having some false negatives. There are some people who are phobic, but for whatever reason their score falls below whatever number B is, and they're being missed. They are being given a false negative evaluation or decision. And you can imagine we could drop the gain or equivalently raise the cut score even more to point C, whatever number that corresponds to. This is good. Now we have no false positives, but we've got a fair amount of false negatives. We've missed a fair number of our phobic people by raising the cut score or dropping the gain on our sort of radar system, if you will. So we're not exactly sure where to put this cut score, and we want to try some different options. In order to do that, we administer our test to 100 participants, and let's just say we know ahead of time, because we've interviewed them all with a gold standard, well-trained diagnostician, that 50 of those people have the disorder and 50 of them do not. So we know this for fact, and now the question is, how well or how poorly will our test work at detecting these people? What will be the relative numbers of hits and misses when we set our gain, when we set our cut score at different points? And we can actually just work with our data. We can try our cut score at 1, we can try it at 2, 3, 4, 5, all the way up to 10. Remember, the maximum possible value is 10. And we can just count the number of people in each of those range who are diagnosed with the disorder and without the disorder based on our cut scores. So as you can see, as we adjust the cut scores, kind of the mix or the proportion of people who are diagnosed and not diagnosed is going to change. If we want to get a little bit more complicated, we can compute proportions. True status, whether or not they have the disorder, test result, whatever the test indicates. We can look at sensitivity and specificity at different cut scores. So let's say we put the cut score at the division between 5 and 6. What's going to be the sensitivity of the test at that point, and what's going to be the specificity of the test at that point? And we can do the same at the cut score of between 6 and 7, and between 7 and 8, or between 4 and 5. We can kind of move that cut score up and down each time, quickly calculating or having our spreadsheet calculate for us sensitivity, specificity, false negative proportion, false positive proportion, and so on. Because we really like tables and graphs, we make a big table of sensitivity and 1 minus specificity for each of these points. So that is sensitivity and the false positive proportion at each of these points. Sensitivity is the probability of test positive given status positive, and false positive proportion is the probability of test positive given status negative. So we like compare each of those two calculations at each level of our cut score. And you can see that they kind of vary across the levels or across the different values of our cut scores. And we make a graph of that. We graph it, and this is a receiver operator characteristic curve or ROC curve graph. And this is exactly what people used to do back in the days of old analog radar during World War II and later, and it's what we do now in some modern psychometrics. This graph gives us an ability to look at the relationship between sensitivity and false positive proportion at different levels of cut score. So why might we care about this? Well, we know that there are different types of tests. There's the ideal perfect test, which never has any false positives, which is always perfectly sensitive That's the test that would have a ROC curve that is like this sort of rectilinear box that you can see on the far left. It's 100% sensitive at its cut point. And a perfectly useless test would be one that had a diagonal line. For each increment of sensitivity, it loses specificity or increases its false positive proportion. So every time it sort of gets better at true positives, it gets better or worse, I suppose, at committing more false positives. By the way, I know this graph is a little bit confusing because on the x-axis I have specificity plotted. In the previous slide it was false positive proportion. They're the same thing, provided that in this picture here I've reversed the x-axis so that it goes from low to high to low instead of low to high. The point of this is, and not to get stuck on the details, is that a perfect test is going to hit its maximum sensitivity immediately, and a terrible test, for every increase in sensitivity, it gets worse in specificity. And the reality is our actual test is going to be somewhere between perfectly great and perfectly useless. And where it is going to be defined or sort of described by a curve, our actual test's curve. And what we can do is we can select the cut point that is at the kind of inflection or the sort of the most outward bowing of that curve. That's going to be the point that maximizes our sensitivity given our false positive proportion. It's going to be what's the best true positive rate we get given our false positive rate. Like how do we select the best test while minimizing the errors? That's going to be, in this case, at the 7/8 division point here. We can also calculate the area under the curve, the AUC, and compare it to the AUC for the perfectly useless test. So how much better our test is than useless is going to be the entire region under it shaded as compared to only that triangular region under it shaded. So you can imagine if the curve bows way out from the triangle, that's a pretty good test because it's getting closer to the ideal perfect test. But if it really only slightly nudges out of that triangle, then our test is barely better than useless. So we can create quantitative representations of how much better our test is than useless, and we can also get some hints as to how to pick a good cut point. We can even take this logic and compare two ROC curves. So if we have two ROC curves for two different tests, it could be the case that the lines for those two tests don't cross, in which case we just pick the one that's got the better AUC. Like imagine you've got two tests for this putative disease or disorder. One of them bows only slightly out of the triangle. The other one bows and curves quite a lot more out. Well, the one that curves more out is the better test. Especially if the two lines of their respective curves don't cross. If it gets fussy and complicated if their lines cross, but we can still then compute a partial area under the curve for a range of interest and just pick the higher one within that partial range. So again, let's imagine we've got two tests, test A and test B. It's not massively obvious that one is better in terms of bowing away from the triangle, which isn't quite shaded here. But we could compute within a particular range of scores which one does better as kind of a low gain test, which one does better as a high gain test. So what's the right cut score? Again, it depends on sensitivity and specificity. It also depends, of course, on costs and benefits. And not that you need to memorize this formula, but here's a formula for optimizing a test, and the only thing to focus on here is it involves both the probabilities of false positives and true positives. It also includes the benefits and costs, that's the B's and C's there, of true positives versus false positives divided by true positive versus false negatives. You don't need to memorize this formula. I'm only showing it to you because it's one of an example of test optimization formulas that tries to integrate both things like sensitivity and specificity that we've covered, and also ideas about how do you balance costs and benefits. We don't need to get into that too much for this class. Just suffice it to say that this exists and that whether you do it mathematically or if you do it more kind of intuitively, whenever you're trying to decide the right cut score, some of it you can get to with the math, like a ROC curve, some of it you have to get to just by thinking about costs and benefits and trying to balance them at different points of cutting. Gosh, thanks for your attention. I know this has been a bit of a long lecture and kind of technical, but I hope you could kind of follow the central theme, the metaphor of the radar operator, perhaps. If you made it this far, just relax, get yourself a little espresso with a chocolate or maybe a bit of hazelnut milk or whatever that is there. Rest, relax, and let all this stuff sink in. I hope it makes sense to you. If it doesn't, of course, as always, ask me questions. And as always, thanks so much for your attention. Bye-bye.